At Professional Risk Management Services, our medical liability insurance program for psychiatrists and behavioral health group practices, the Psychiatrist Program, is designed to meet your needs throughout the various stages of your career. As a national psychiatry-specific program, a policy with PRMS can cover child and adolescent, forensic, early career, and military psychiatrists, as well as moonlighting residents and fellows, part-time practitioners, and telepsychiatrists. Learn more about how PRMS can protect you.
Hello, everyone. Welcome to the Washington Psychiatric Society podcast. I'm Dr. Misarov, psychiatry resident at St. Elizabeth's Hospital, and we're going to speak with Dr. Robert Post. Let me introduce him. Dr. Post graduated from Yale University and the University of Pennsylvania School of Medicine. He completed his psychiatry residency at Massachusetts General Hospital, National Institute of Mental Health, and George Washington University. Dr. Post has devoted his career, including 36 years at the National Institute of Mental Health and 20 of those as chief of the biological psychiatry branch. He devoted to the treatment of refractory bipolar disorder and unipolar depression. He has published 1,080 manuscripts and has received 22 national and international awards. Dr. Post also founded the International Society, it's called International Stanley Foundation Bipolar Network, and now known as the Bipolar Collaborative Network. Dr. Post, would you tell us more about that network?
Yeah, I'd be happy to. We had 900 patients, outpatients with bipolar disorder, and 4 different sites in the US and 3 in Europe, Netherlands and Germany. And amazingly enough, we found out that everything about the illness was much more difficult, was worse in the United States than in Europe. More early onset illness, more treatment refractoriness, more anxiety and substance abuse comorbidity, more rapid cycling, more treatment refractoriness, everything like that was more problematic. So the US people who are on this call know that they've got more difficult patients here in the US. And one of the things that we found was that in terms of early onset, the US had more genetic vulnerability and more psychosocial stress. And those two went along with early onset illness and a more difficult course. So we followed all these patients with daily ratings, and we came up with all sorts of things about the course of illness.
Could you share with us, could you share with us your insight? Why do you think the situation is so different in the United States?
Yeah. Well, I think we've got lots of vulnerability factors. In addition to the genetics that I mentioned, we also have more psychosocial stress, more childhood adversity, and that is a risk factor for early onset illness. We also have many other things like more obesity, worse diet, those kinds of things. I think they all sum up to lead to a more difficult illness.
And I remember you recently mentioned, we had a conversation while preparing for this interview. You mentioned something about epigenetics too, right?
Yeah. Yeah, I think it's pretty clear. Lars Kessing has described this as a progressive illness. The more episodes you have, the faster they come, the more difficult they are to treat, the more severe they are, the more cognitive impairment. All of these things go downhill. And we think we know some of the mechanisms for, because every episode leaves behind a epigenetic trace, and stresses also do that, and substance abuse use also does that. And if you accumulate lots of these adverse epigenetic markers, that can push the illness downhill pretty rapidly. The other thing about the epigenetic markers is that it gives another vulnerability in addition to the genetics because they now have found that some of the epigenetic marks get passed uh, um, to different transgenerationally. So the best example of that is if a daddy rat um, is conditioned to a smell, his offspring that he never sees is more reactive to that smell and has more smell receptors. So there's something about the epigenetics that pass on to the next generation. And that happens in people as well.
Wow, that's very insightful. In 2025, I remember I was reading a study, it was published, in which researchers grouped 14 psychiatric disorders into five clusters based on their genetic profiles. And bipolar disorder was actually classified within the same cluster as schizophrenia. Do you agree with this classification?
Pretty much, because a good number of patients have psychosis with their bipolar illness. But the good thing is that the folks with bipolar illness who are psychotic have as good a response to lithium and other things as the non-psychotic ones. So there's something different there in terms of it not being as severe in an illness.
Yeah. Thank you for sharing that. You mentioned lithium, and I remember you were talking about the neuroprotective properties of lithium. Could you tell us a little bit more about that?
Yeah, lithium is way underutilized in the United States and elsewhere. We now think it's meets the criteria as a disease-modifying drug, just like in rheumatoid arthritis, where if you treat it early and well, you don't get illness progression and you don't get the anatomical changes. And lithium does that. It increases BDNF. It increases hippocampal volume. It actually protects memory and it increases longevity and it increases the length of somebody's telomeres, which is amazing. Because if as the telomeres get short with aging and more episodes, the cells take themselves offline and people are more prone to both medical and psychiatric illnesses. The other new thing that just came out is kind of amazing. In Nature, a guy named Aron, Aron et al., has found that people with mild cognitive impairment and Alzheimer's disease have a deficit of lithium in their brains,
Uh,
not in their blood, but in their brains. And he made an animal model of this by feeding animals low lithium in the diet. And they got confused and they had all kinds of biochemical changes that go along with Alzheimer's disease. And the amazing thing was that he found that a specific kind of lithium called lithium orotate, which is available very cheaply in health food stores, that was the best drug for reversing the memory deficits because it does not get caught up in the plaques in the brain the way regular lithium does. So lithium orotate, watch out for this, folks. It's going to be on the radar as something that may be very, very impressive for cognitive impairment.
hmm. Yeah, maybe we all should soon consider as a this as a supplement, the dietary supplement we can use, we can add.
Yeah, I and my wife and a whole bunch of our friends have already started doing that.
Wow.
Yeah.
Oh, that's impressive. Thank you. So what do you think was your key publication? I know you were a pioneer in many, many, many different topics related bipolar disorder, carbamazepine, lithium, kindling, early onset bipolar disorder, and many, many of them. What do you think is your key publication?
Yeah, I think I think the key one is one on the longitudinal course of illness, where we emphasize that it's a progressive illness, and there's sensitization to recurrent episodes and a kindling-like process where the more episodes you have, the faster they come and the more automatically they come. So that was a key element in all of this. And when we did that in 1972, we didn't know the mechanism, but now we know at least some of the mechanisms, and there's these epigenetic changes. These marks are left behind by episode stresses and substance abuse, and this accounts to some extent for the illness progression. So that paper kind of characterized the course of illness and put it in there as something that needed to be treated well and early, which is not often the case in the US. It's often neglected and not treated very well. And that's a double whammy because the earlier it starts, the more poorly it goes. The earlier it starts, the longer the delay to first treatment. And that results in all kinds of disabilities. So getting after the illness early and well is the name of the game.
Mm-hmm. Mm-hmm. Thank you. Dr. Post, based on your current experience and your current knowledge, would you reconsider any of your revisit or reconsider any of your publications? Do you think you disagree with any of them?
Um, no, I think the only one I kind of missed out on is ways of trying to stop kindling. We can stop kindled seizures with anticonvulsants, but we were trying to come up with some way of quenching the kindling and taking it offline, and we're never quite able to do that. So that's the one that I regret not having enough time to figure it out.
Uh-huh. Thank you for sharing with us. Um, how did you become interested in researching bipolar disorder?
Yeah, came to the NIMH in part to avoid going to Vietnam, and they put me on Fred Goodwin's unit, and he was studying patients with bipolar disorder. And I was totally amazed to see some of these patients who were mute one day and running around crazy, talking as fast as possible the next. And then it seemed to me that there was some kind of neurobiology going on there, and it would be nice to be able to figure out how to smooth out that switch result.
Mm-hmm. Mm-hmm. Wow. Since we emphasize leadership and mentorship on this podcast. My question for you is, which mentor had the greatest influence on your professional development?
Yeah, Fred Goodwin did, and he always emphasized the longitudinal course of illness. And then Biff Bunny also came in and went into the drug abuse area as well as bipolar illness. And those two really helped foster my career big time. Yeah.
Uh-huh. Uh-huh. How do you think trainees should today choose their mentors?
Yeah, that's a good one. I would I would choose someone in an area that the mentee was himself interested or herself interested in, and so that you could take that series of ideas and run with them. Uh, and if you don't find someone like that right off the bat, to get into the area that the leader is interested in himself and see if you can take it to the next step. So, kind of using your own interest and using the interest of your mentor, I think is the way to go. And,
Hmm. That's a
and
really important point. Sorry.
yeah, I found that was one of the most important things in my mentoring of folks is to encourage them to follow their own noses, if you will. I had people who were saying, well, it, it's it's not just serotonin that's important, dopamine's important. John Carmen said calcium's important. Another person said that there was a person on our unit had multiple personality disorder, and at first I kind of said, "Wow, that's something else." But then this person ended up having 20 personalities, and this doc went on to be the leader in multiple personality disorder. So
Mhm.
finding a niche and pursuing it and encouraging other people to follow it is the name of the game. And I actually learned as much from the other doctors on our unit and the patients as I did in terms of teaching them. So the exchange back and forth is critical for the mentoring.
Have you do you remember any lessons maybe that any of your mentees taught you? Any of your maybe residents or students taught you?
Um, yeah, the calcium story turned out to be an important one. The dopamine story. The other thing is that a friend of mine out on the West Coast has data that you really need to treat the first mania very well and carefully because after the first mania, you lose some cognition and you get it back as long as you don't have another episode.
Uh-huh.
Lakshmi Latham found this and it's been replicated by other people. So the idea is to get after the illness well, even after the first mania. The other thing is that there's data in the literature now that people who take lithium intermittently don't have the same longevity as the people who take it continuously. So
Mm.
intermittent lithium is not as good as continuous lithium for your longevity. So getting on the right meds and staying on the right meds is the name of the game.
Yeah. Um, in our recent conversation, you mentioned calcium channel blockers, and that really fascinated me. Your experience working using them as a tool, as a mood stabilizer. Could you share with us? I think it is going to be very important and very helpful, and probably some of us, as I didn't know about the use of that.
Yeah, we were looking for things for people who didn't respond that well to lithium and came up with the anticonvulsant carbamazepine. And then we also came up with the calcium channel blocker, nimodipine, which is a dihydropyridine calcium channel blocker. And it works in very ultra rapid cycling patients and even ultradian cycling. We had one patient who was up and down 5 times in a day, and she responded beautifully to nimodipine. And now there's a genetic link to that too. There's a gene called CACNA1C, which lets too much calcium come running in, and the people who have that gene are more prone to depression and bipolar disorder. So we're using a lot of nimodipine, and we did it in an unusual way. Um, we didn't have that many patients on it, but we had every patient on it in a double-blind fashion, on, off, and we proved that some of these patients really did stop cycling on the nimodipine. They relapsed off, and then they stopped again on the drug. So it never got recognition in the field, but I now use it a lot, and there are data out there that lithium plus nimodipine work better than either drug alone. And if somebody can't tolerate lithium, nimodipine is a very good adjunct.
Thank you for the explanation. I'm pretty sure some of the people will ask maybe about the doses, like what doses you prefer, but we can postpone to the question and answer section.
Yeah, yeah.
Hmm.
Uh, the other thing that I use a lot are supplements. Um, I have people go to the health food store and buy the supplements even before going to the major meds, one of which is N-acetylcysteine, which has an amazing profile of dealing with stabilizing bipolar illness, but it also helps with substance abuse avoidance. Every single substance, including marijuana in youngsters, is placebo-controlled trials with it. Um, Stimulants, opiates, and it's also an adjunct in OCD to the SSRIs. So it's a really good one to use. The other one is acetyl L-carnitine, which they have found is low in the blood of patients with recurrent treatment-resistant depression. And if you treat those patients with acetyl L-carnitine, they have good antidepressant responses, and they found out what it does is it turns on an inhibitory receptor that decreases glutamate release. Um, and it looks like this one is an epigenetic mechanism and it works pretty quickly. The other thing that I use a lot is L-methylfolate rather than regular folate because about 15–20% of people have the methyl tetrahydrofolate reductase deficiency and can't convert regular folate to methylfolate very easily. So and that's another one that I take since I have that gene defect. The other thing is vitamin D3 is good, higher doses, 4,000 international units is better than lower doses for cognition. So I tend to use a lot of these supplements as kind of adjunct drugs before I go on to the main ones. And the main ones that I use, the key thing I think is to use drugs that are well tolerated and to choose that even over sometimes the evidence for efficacy, because our patients are prone to the metabolic syndrome and all kinds of other things, including heart attacks and strokes and all that. So we want to make sure that we're not adding to their medical problems with these drugs. So we're lucky now that we're having more drugs um, with fewer problems associated with them. One of the things that I found in my review of lithium as a disease-modifying drug is that lithium actually is no more prone to weight gain than placebo.
Hmm.
The reviewer says, "Oh, you can't say that. Well, how does that work?" So I found a review article where there were about 15 controlled studies, and every single one of them had lithium not having excess weight gain. So I think the problem with lithium is people emphasize its side effects and minimize its benefits. And we really need to use more lithium and earlier in the course of illness. Lars Kessing has data that people who start lithium early in the course of illness have a better outcome than those who start it late.
Uh-huh. Uh-huh. I see. I'm sure most of us now are curious about all of your supplements that you know of and your list of supplements you take. So we all want to benefit our health. So
Yeah,
maybe you're going to share with us when we have a question and answer section.
yeah, sure, absolutely.
While preparing for this interview, I noticed that you're currently working in private practice. and it says on your website that you're providing second opinions, consultations. So, what do you think some clinicians most commonly miss when they're diagnosing bipolar disorder?
Yeah, I think I think there's quite a literature on looking at people with unipolar depression in those kinds of clinics, and it turns out that about 30% of those folks actually have bipolar too. So I ask every patient who's depressed, have they ever had a period of increased energy and decreased need for sleep? And if they say yes to those things, then I go into the idea that they may have bipolar illness in more detail. The other thing is that in children, ADHD and bipolar are highly comorbid, and often patients are being treated by pediatricians who are not as up on bipolar as they are on ADHD. So, what you need to do is find out what things are related to bipolar illness and not ADHD. We did a study with Bob Findling and found out that the kids who go on to have bipolar disorder have decreased sleep, increased euphoria, increased aggression, suicidal ideas, homicidal ideas, delusions and hallucinations, and hypersexuality. And if those are present, it almost always means that the kid has bipolar and comorbid ADHD, and you need to stabilize the bipolar disorder first and then treat with stimulants for the residual ADHD. So getting the illness right from the get-go is important. But even in adults, there's so many patients who are uh, treated with antidepressants when they have bipolar 2, and the literature is kind of mixed on how bad antidepressants are for you. And now there's a fair percentage of people that look like they're switching on antidepressants in monotherapy, and not so much when the antidepressants are given with an anticonvulsant or an atypical antipsychotic mood stabilizer. So avoiding the antidepressants in someone who's bipolar 2, I think, is the way to go.
Thank you. That's very insightful. And I'm pretty sure that we have some questions already. I see at least one of them here, so we can gradually proceed to them. But at the same time, if anyone wants to ask question, you can turn on your camera and your audio and ask question. And one question I see in on the comment section in the chat, it's what dose of lithium orotate does Dr. Post recommend?
Yeah, well, that's a good one because I just take the lowest dose that they have, which is 5 milligrams, because the dose was not well worked out and what treated these animals. So don't really know whether 5 milligrams is right, but 5 milligrams of lithium orotate is obviously an extremely low dose compared with our clinical doses of lithium and has no side effects. So we have to see what the right dose is as the literature develops on this. But I'm I'm taking the 5 milligrams and hoping that that's enough.
Thank you. And we have a question from Dr. Perman.
Yeah, hi. Thanks, Bob. Good to hear you today. And I have to begin by thanking you for your contributions to Capital Psychiatry. In the most recent issue, it's available on the WPS website from January, a brief communication evidence of substandard care in the U.S. and even in Canada regarding the underprescribing of lithium in both countries. You mentioned that people tend to pay more attention to the side effects sometimes than the benefits of lithium, and it's certainly the case because of I guess mainly the concern about effects on the kidneys, to a lesser extent maybe the thyroid, but both of them need to be monitored because there have been cases where patients have been treated with lithium for long periods of time, and the kidneys had not been adequately looked at, and then they've gotten into trouble. Although I imagine it's extremely rare, but and before I just have you address that, it's reassuring that the lithium orotate, is a 5 milligram dose as opposed to multiples of 300 milligrams, which is the standard lithium pill.
Yeah,
Thanks, Bob.
well, we don't know whether lithium orotate is going to be sufficient to treat bipolar disorder. It only so far has been kind of proven in these animal models to deal with the lithium deficit in brain and cognition.
Yeah,
So,
that's what I wanted for. Thank you for myself.
yeah,
Continue. Yeah.
yeah. The other thing is on the kidney story, turns out that there's uh, two large international studies, one um, uh, from Europe and one from Israel, that looked at people who had kidney failure, and it turned out that the incidence of kidney failure on lithium was not any higher than the people who were treated with anticonvulsants. So even that one is a little overblown. And the other one is the thyroid. Obviously, you need to check out the thyroid, but some people say lithium is thyroid toxic, but that's sort of a misnomer since it's very easy to replace thyroid if you have some lithium-induced deficits in thyroid function. So there's lots of things about lithium that are kind of overdrawn for their side effects, and people don't know enough about the positive effects. And I'm ashamed to say this, but I end up telling some of my patients about their telomeres, and they like the idea that their telomeres have more DNA on the end of them, and like that better than it's treating the illness per se. So,
Just
give
one follow-up point. It's very
it,
Freudian, especially with men, to tell them that their telomeres will become longer if they take lithium. So
yeah.
I think that could be an added psychological benefit to lithium. Yes, thank you.
Yeah, absolutely. Psychological benefit, but also actually a clinical and medical benefit, since the shorter your telomeres get, the more problems you have with medical and psychiatric illnesses. So that's a that's a really good one.
We have another question.
Yes, this is Dr. Piri Patel, and I have two questions. In past, I have thought of using acetyl L-carnitine, and I would check the levels, and many times levels are n- normal, and I have been hesitant using it. Do you always check ALC levels?
Acetyl L-carnitine, no, I don't check those levels per se. The data are that from Rockefeller that the people who had treatment-resistant unipolar patient had the lowest levels, and those who had childhood onset and more severe illness had the lowest levels, and also the ones who had childhood adversity had the lowest levels. And there's an animal model of defeat stress where you put a little animal next to a big guy that tries to beat it up all the time, and that animal gets depressed. And it turns out that that defeat stress animal has low levels of acetyl L-carnitine, and if you give it, the animal gets better in 3 days as opposed to antidepressants that take 2 to 3 weeks. So There's a fair bit of data out there uh, about the low levels, and if you can measure them, you may be doing better than most of us. I kind of put that in there with anybody who has treatment refractory unipolar illness and a childhood adversity history. And I think we need to study that as something that might be helpful to kids with bipolar disorder, because kids with bipolar disorder are twice as likely to have childhood adversity compared to controls. So maybe that could help with with their course of illness, but that has not been studied. It's one of those things that no drug company would study because it can't make money on it.
You are absolutely right. And that was my second question. Has all atypical use increased the incidence of the bipolar we are seeing or rapid bipolar illness we are seeing?
No, I don't think it's the atypicals that are doing it, but the data in the US are striking that the use of atypicals has gone way up and the use of lithium has gone way down. And there is evidence of a cohort effect where people in more recent generations have uh, more illness and more early onset illness. And the early onset, I don't think, is related to neuroleptic treatment. So I think it's a cohort effect where the illness is becoming more prevalent.
On this
This is
topic,
Connie Dunlap. Actually, I think you may not be able to see that my hand is raised. I just want to ask a question that's related to what has been posed. Dr. Post, thank you for this really nice review of your work. And my question is just based on what you've shared, I'm wondering if, with all things equal, you have a patient, it's clear there's a bipolar pattern, would you recommend lithium over an atypical antipsychotic? And I'm asking, I've practiced long enough to remember when lithium was the recommended treatment, and younger generations are being trained to reach for something like Depakote or Seroquel. And I'm wondering if, assuming that the kidneys are fine, the liver is fine, in other words, the organic workup is unremarkable, am I hearing that you would recommend lithium over the atypicals?
Um, yeah, in some instances, and if somebody's in real troubles and you want to get them better the fastest, both drugs, the atypicals and lithium in concert would be a good idea. Um, there's a study in Australia done by Burke that looked at patients with a first episode of mania who were randomized to either Seroquel or lithium. And it turned out that those who were randomized to lithium did better in all respects. They had less illness and their brains looked better and all that kind of stuff. So lithium is doing some things in a positive way in terms of its neuroprotective and neurotrophic effects that some of the other drugs are not. The uh, the other thing is it's nice that we have some neuroleptics now that have a good side effects profile, less weight gain, like lurasidone is weight neutral and it's FDA approved for kids 10 to 17. And the interesting thing about lurasidone is that it works better in both kids and adults who have evidence of inflammation by high levels of C-reactive protein. So we always think that the ones who have inflammation are harder to treat, but the lurasidone looks like it actually does better in those with inflammation. Some of the other new ones are also well tolerated, so we have some choices where we don't have to go with drugs that have big problems with weight gain.
thank you, Dr. Post.
Thank you.
I apologize. Someone who asked question right before Dr. Dunlap Could you introduce yourself? We just see your iPhone, and we don't know um, your first or last name, unfortunately.
I think that was the person who had asked the two questions before.
Right.
Yeah,
I think,
before.
Sorry, yeah, yeah.
yeah.
But
Doc,
Dr. Walgerman has had his
right.
hand up for a while.
Thanks.
So I'd be
Thanks,
interested.
Jerry. Yeah, I just wanted to follow up on this issue of the underutilization of lithium. That's bothered me for many years. It bothers me even more after hearing Robert Whitaker give a talk at Georgetown last week. He had a massive amount of data about how much our specialty has really been misinformed by the influence of pharmaceutical companies. As you said, they can't make much of a profit from lithium, so they're not much interested. I'm surprised again and again, as Connie said, younger psychiatrists, all they've heard about lithium is problem with kidneys and so on, and they're afraid to prescribe it. Is there any way we can persuade a journal like the American Journal of Psychiatry to give psychiatrists a more balanced view of the appropriate role of lithium?
Yeah, I've been trying to do that with the idea that it's going to be very difficult to change.
Mhm.
But I've been writing about lithium as this disease modifying drug. I've been writing articles about what parents need to know about lithium and its positive attributes. But there needs to be some other kind of move that really moves the field because uh, we're so entrenched in as you're saying, and not using lithium and not learning enough about it. So it almost looks like it needs some kind of remedial teaching to the new residents and needs to be mandatory that some of that information is given to them. It's really a tough one. It's it's like not using a drug that can do all sorts of good things to the person in the brain, including uh, lower the levels of dementia and old age and increasing longevity and all these kinds of things that are pretty amazing. And no one e- either pays attention to that or knows that. So as much as much as we can kind of push that story, I think it's going to be helpful. And we need to do it and teaching the youngsters as you're pointing out. It's going to be a tough one because people are so ingrained in the opposite.
They are. They sure are. Thank you.
So my mantra for patients is prevent episodes, protect the brain. And we know that lithium is one of the things that prevents the prefrontal cortical deficits that come with too many episodes. That's another thing that lithium can do and puts it in the realm of a disease modifying drug. I had hoped that if you called it a disease modifying drug, that would help patients and physicians and clinicians use it more and earlier, but don't really know how to get that message across.
One thing I've told patients is that as I remember, animal models of stroke have shown that pre-treated animals have a faster recovery from an experimentally induced stroke.
Yeah, it's amazing that lithium will, if you tie off the middle cerebral artery, the Chuang in our group did that. The lesion is half the size. And it's the same with so many other neurological diseases that lithium actually protects against. So, yeah, it's got all these other positives that are not well known.
Thank you, Dr. Post. So we have a time for one maybe quick question.
Okay, well, one comment I want to give before that question is that we have a newsletter that used to be bipolarnews.org, but it got taken offline and now it's bipolar-news.org. And I try to write all the latest data in the literature about that in that newsletter, and patients and clinicians who read it seem to like it a lot. So it can be recommended uh, to patients and other clinicians. And I try to get the lithium story written in there as well. So sorry to interrupt you. You had one last question?
No, we're just waiting if someone maybe have one quick question before we wrap up.
If I could, not a question, just a comment. Thank you so much, Dr. Post. This is Todd Cox. And I just want to thank you for all of your insightful and incredibly useful consultations that I've asked you for over the years, as well as so many of my colleagues. And I think that it's easy to say that I use many of your reports as examples for medical students and residents in terms of how to think about the psychopharmacology and the options that exist, and to do it in an evidence-based fashion. And so I just want to thank you tremendously for the services that you provide, and the enriching of the experience for collaborative care, but also for being a major source of teaching for the students and the residents that I've interacted with.
Oh, that's very kind of you. And that reminds me of one last issue, and that is that the FDA approves drugs that beat placebo, and we really need to work on patients to treat them to remission, because that's what they want. And that's a tougher thing to do, and it often takes multiple medicines in combination. And that's one of my big takeaways from my stay at NIH, that if you use a lot of different meds that work on different systems, you can do it better and you can actually have fewer side effects, contrary to what the literature says. But I appreciate your positive about the consults. Often I don't hear how patients are doing, so it's very nice to hear that some of them have done well. Thanks.
And thank you, Dr. Post. And I wanted to say that I appreciate everyone for having this great discussion and for being with us.
Yeah, well, thanks for the invite. I appreciate it. And thanks for everybody joining in and remembering that all the bipolar patients in the US are tougher to treat than anywhere else. So keep up the good work.